I have 30 minutes to do 12 cranial nerves with you all. So I was thinking that's a little bit like, who's from New York here? Like asking Carrie Bradshaw or Will Truman to spend 30 minutes in a Barney sale, right? Where do you start? But we're gonna do it, I promised Tina I'd get through all 12. And for each of the cranial nerves, we're going to try to answer some questions. First of all, when do you look for them? When do you need to look for them? What are the indications? How do patients present? And what does that mean for your protocols? The second is, how do you find them? So we'll look at the imaging anatomy and the technique that we use to look at the cranial nerves. And third, we'll look at some cases that will hopefully illustrate some search strategies that help you to identify the pathology. So for cranial nerve 1, I'm going to put you right in the driver's seat. Now, this is one of the challenges of doing cranial nerve imaging. During the breakfast beat, I got stuck with the smelly nerve as my first nerve, but here you go. So we're going to start with olfactory nerve number 1, and you're going to get referrals either from the pediatric endocrinologists or from the pediatric ENTs for patients with olfactory disturbances. And if you're an ENT, it's a little bit different when you're working in the ENT world than when you're working in, for instance, with the neurosurgeons, because they go right in with the endoscope. There's no question of whether or not to do a craniotomy or not. So they're going to go right in and do a nasal endoscopy and look in the nasal cavity. And if they see abnormal nasal mucosa, no? Okay, I'll use it then, okay. So if you look, as you see on the right side, if you're the endoscopist and you look in the nasal cavity and you see this, polyps, you're gonna treat the patient with antihistamines, send them home, do some topical steroids and see them later. But if you look in the nasal mucosa and you see up in the olfactory groove, normal mucosa, here's the septum here and the middle turbinate here, then you start to think of other causes. You ask about a history of trauma, or you may ask for, start to think about neurologic causes, and that's where we may come in imaging. So if one looks at the incidence of olfactory disturbance over time, one sees that it's relatively low in the pediatric population. It starts to rise in adulthood and can reach and is probably associated with neurodegenerative disorders like Alzheimer and Parkinson. But if one looks at whether or not MR plays a role in neuroimaging, a little bit different in the pediatric side than the adult side. Some studies have shown that MR plays very little role in actually changing management of patients with olfactory disturbances. But in children, up to maybe 60% of the time, although the numbers tend to be smaller in studies of children, MRI can change management and can show pathology. And that may have to do with the presence of ventral forebrain patterning malformations in children that are associated with olfactory disturbances. So we know that the olfactory nerves, that the primary olfactory neurons live in the roof of the nasal cavity, and they synapse along the olfactory groove and form second-order neurons that are actually the olfactory nerves that we image, and those can be followed back either medially into the medial or lateral olfactory stria that communicate and talk to structures in the limbic lobe. And so what you're going to need for your imaging is a good coronal T2 weighted sequence that shows the olfactory nerves in the olfactory grooves surrounded by CSF, and then a good KISS sequence, or 3D Fiesta, or 3D drive sequence that shows the here in the axial plane, the olfactory nerve extending back posteriorly and dividing into medial and lateral olfactory stria. This 12-year-old boy presented with short stature all his life, and then the family noticed as he got older that he was very unaffected by very strong odors, so I won't go into the strong odors, what they noticed, but here is compared to the normal reference, you're going to use the coronal T2 weighted sequences to evaluate the olfactory groove, as opposed to the normal patient where you see the olfactory nerves in the olfactory grooves. Here, you never quite see normally formed olfactory nerves. And secondly, you do not see a median olfactory sulcus that divides the gyrus rectus normally from the medial orbital gyrus. If those are features that you see, you can be pretty certain that this is some sort of a ventral forebrain patterning malformation, something probably in a Kalman type spectrum. And then we usually use an SPGR or MP RAGE sequence to look at the midline structures. Here you can see there's a normal adenohypophysis, or an adenohypophysis and a neurohypophysis. The adenohypophysis here looks a little bit flat, a little bit crescentic. and the corpus callosum here has a somewhat unusual configuration. So we don't actually have the gene in this patient, but the spectrum of genes associated with this disorder that many of us, I think, grew up knowing as Kallmann syndrome was actually expanded. If one looks in OMIM, one sees that there are actually at least 21 genes, the last time I looked, that are associated with this Kallmann-type phenotype that's named hypogonadotropic hypogonadism with or without anosmia. Some of them may just produce isolated or more isolated malformation of the optic pathways, but some of them are associated with genes that have other associated phenotypes like craniosynostoses, some in the charge phenotype, and even others in Waardenburg phenotype like SOX10 or even Wolfram syndrome. So the association of olfactory disturbances with malformations with different syndromes continues to expand. We know that vision loss back in 2010 was estimated to affect about 18 or 19 million patients worldwide, or children worldwide, according to some studies, and 1.4 million blind children back in 2010. If one looks, it's interesting to look at the causes of either visual impairment in adults, many of which are secondary to refractive errors or cataracts, and blindness, mostly secondary to cataracts, as opposed to causes of vision loss in children, where cortical visual impairment or optic nerve hypoplasia, optic atrophy. So many of the disorders where neuroimaging may be important play a more important role in causing visual impairment in children. So I'm going to put you back in the driver's seat, and instead of using an endoscope this time, you're going to use a fundoscope. You're going to look at the back of the patient's eye, just as would a pediatric ophthalmologist who would refer the patient to you. And I think it's helpful to have in mind what the ophthalmologist is actually seeing as we image patients, as we develop protocols for the patients, and as we, again, evaluate the images. So if you're an ophthalmologist seeing a child with vision loss, you're going to do a fundoscopy, and instead of the normal fundus, as you're seeing here, you may see either a very pallid optic nerve, an abnormally white optic nerve, or a hypoplastic optic nerve, or a swollen optic nerve. And in any of these conditions, you may send the patient for neuroimaging and have some particular questions. For instance, if the nerve is particularly pallid, you may wonder if it's a compressive optic neuropathy, maybe associated with periventricular leukomalacia, or an inherited optic neuropathy, as opposed to a hypoplastic nerve that may be associated with different genes, again, that are involved in ventral forebrain patterning, or a swollen optic nerve, which is often considered an emergency where we're concerned about papilledema. And you're familiar with the anatomy of the optic tract, where the right visual field or information from the right visual field is interpreted by the left visual cortex, and from the left visual field back to the right occipital cortex. And depending on the evaluation of fields, which often the ophthalmologist will do before they send the patient to us, that can help us to identify the point of the lesion. Most of the optic nerve lives within the orbit, although there are important parts of the optic nerve, for instance, the canalicular segment of the optic nerve that travels between portions of the lesser sphenoid wing, and then the cisternal portion of the optic nerve that travels back to the chiasm, and then the post-chiasmatic optic tracts. And you'll use a coronal T2 weighted sequence to visualize most of those portions of the optic nerve. Here's a coronal T2 showing you the normal signal within the optic nerve. The litmus test for optic nerve pathology is comparing the central portion of the optic nerve to the frontal white matter, especially in children over 2 years of age. These should be pretty much isointense to one another. And then coming back into the canalicular segment, and then the cisternal segment of the nerve back into the chiasm. And we often also use a KISS sequence to look at the contours of the nerve, especially good for looking at the cisternal portion of the nerve traveling back to the chiasm, and then the post-chiasmatic portions of the optic tracts. So this boy had developmental delay since the age of 2 and had an eye exam showing some peripapillary pallor or gliosis. So remember that first image that I showed you in the upper right of a pallid, abnormally white nerve. And here you can see a correlation to that on the coronal T2 weighted images as a normal hyperintense signal on the T2 weighted images within the central portion of the optic nerve. And here's the image for normal reference below. And looking intracranially, there's a normal signal along the cortical spinal tracts in the periventricular and deep white matter, and this rather characteristic involvement of the perirelandic white matter that would be more suggestive of a GLC mutation or a Krabbe phenotype. Here's a patient, 14-year-old girl. She had 1 month history of worsening headache. She showed up in the Mass Eye and Ear emergency room. She immediately got a fundoscopic exam to evaluate a patient with headache, and she has very swollen appearing optic nerves that were called papilledema, and in fact, she went right to MRI. Here's a normal reference image on the right showing the appearance of the orbital segment of the optic nerve. You can see she has very dilated, comparatively dilated optic nerve sheaths, flattening of the optic nerve head, and then obstructive hydrocephalus, transependymal flow of CSF, secondary to this tumor sitting on the cerebral aqueduct that pathology showed to be a pineal germinoma. Here's a case that's good to keep in mind. This is a 17-year-old girl who thought that it would be a good idea to get her eyes checked out. She had had a recent physical exam and thought it'd be good to just get an eye exam as well. So she went to see her pediatrician, who unfortunately saw something unusual in the back of her eyes and interpreted it as papilledema, and then sent her to an outside hospital. This was one of those outside hospitals, and then eventually had a CT, you know how that goes, and had a CT scan. I should have labeled these images as not done at the Mass General Hospital for Children, but eventually we saw this CT scan that showed these hyperintensities in the posterior aspects of the globes. There we go, here and here, yeah, that were interpreted as drusen. So drusen is in fact one of the sort of classic fake-outs for papilledema, and so it's important to keep in mind that if you have a patient who, when, depending on your confidence in the ophthalmologist's, fundoscopic evaluation, if you have a patient who has no other symptoms consistent with increased intracranial pressure, who has, papilledema on exam, most of the time those patients in our department would just go immediately to a B-scan ultrasound rather than having CT or MRI. But just keep in mind, if you're involved at all in the workup of that patient, that it may be so-called pseudopapilledema. So the next three nerves, 3, 4, and 6, I'm going to introduce to you in the setting of strabismus. Since most of the pediatric ophthalmologists see these patients and send us referrals for evaluations of lesions of cranial nerves 3, 4, and 6, really in the setting of their evaluation of patients with strabismus. So what strabismus is just a misalignment of the eyes. It can be an abnormal esodeviation of the eyes causing esotropia, exodeviation or an exotropia, or a hypertropia where one eye is slightly higher than the other. And that leads to a loss in vision. Or blurry vision. And so patients with exotropia, for instance, would be more associated with lesions of the third cranial nerve, maybe infantile, maybe acquired, secondary, and it's usually the patients with acquired exotropias that come to us for imaging. If one looks at the incidence of exotropia, most of the cases occur, there's a bimodal peak, but most of the cases occur under 11 years of age, where the prevalence can be as high as 1%, and sensory and paralytic causes, where the nerve would be involved, account for about 12% of patients overall. And so the cranial nerve 3, if you look in the literature, has been extensively studied, especially in adults. Here's one patient, 1,400 personally examined inpatients. So the presentation of cranial nerve third palsies often will involve ptosis, limited elevation, depression, and adduction. And in adults at least, a lot of the causes in third cranial nerves, I think that we learn, are associated with either trauma, tumor, or aneurysm. But if one looks at those numbers in children, although again many of the published studies have fewer numbers, many of these cases are congenital. If one looks at, for instance, all comers for third, fourth, and sixth nerve palsies, in black you can see here the number of congenital cases that can present not only in early childhood, but all the way up into the teens, depending on when the patients go for evaluation. At least in this one population-based study, they found that the number of congenital causes was quite high. And among third cranial nerve, again, although the numbers are low, probably about 50% of cases are still congenital. Nevertheless, most cases of cranial nerve third palsy, almost all of them will come to us for imaging because of the suspicion of an associated compressive lesion or tumor. The third cranial nerve has multiple motor components, about 5 motor components that are paired, and one that lives in the middle of the two that participates in both the right and left function. The nerve crosses out through the red nucleus and exits in the mesencephalon and extends right into the cavernous sinus and hangs out in the upper outer portion of the the cavernous sinus, and then comes through the superior orbital fissure and innervates most of the extraocular muscles except for the lateral rectus and superior oblique. And here, what you're going to need is a good axial T2 to look at the brainstem, and then another KISS sequence to look at the cisternal portions of the nerve as they travel here just beneath the posterior cerebral artery. And then within the cavernous sinus and post-gadolinium image, you can actually see the third nerve in the upper superior portion of the cavernous sinus. So here's a 6-month-old boy who presented with a progressive exotropia and ptosis, some of the characteristic features of a third nerve palsy, of a paralysis. You can see here a lesion that's developing in the mesencephalon right along the course of the third cranial nerve. And here on this KISS image, here's the normal nerve on the right, and here's the abnormal nerve that is invested by the tumor as it issues out from the mesencephalon toward the cavernous sinus. This was a patient with an NE1 deletion or an atypical teratoid rhabdoid tumor. The fourth cranial nerve that most characteristically results in a hypertropia and often a head tilt to the contralateral side. So these patients sometimes will present with torticollis as well, and will come to us in the setting of an evaluation for torticollis, has an even higher rate of congenital causes. So most of the time, hypertropias do not come to us for imaging, even if the findings are very consistent with the cranial nerve 4 palsy. But if the patients present later in life with a new onset cranial nerve 4 palsy, since most of the cases, as depicted here in this study by Tollefson, occur under the age of 7, if the patients present to us later in life, then with a new acquired fourth nerve palsy, they may come to us for imaging. The anatomy of the fourth nerve, again, the nuclei live at the level of the inferior tectum. They cross within the brainstem and then come out posteriorly, and then again enter the cavernous sinus. And then the relation between the third and fourth nerve, the fourth lives below the third in the cavernous sinus, inverts within the superior orbital fissure as the fourth nerve heads up toward the superior oblique, and the third nerve assumes a more midline position within the superior orbital fissure, and then the fourth nerve heads out to innervate the superior oblique. And so what are you going to do to image the fourth cranial nerve? Well, you're going to do an axial T2 weighted sequence or a FLAIR to look at the nerve in the brainstem to evaluate the nuclei. And then you're going to do a KISS sequence so that you can be really frustrated and not see the fourth nerve, as most of us do. But at least you'll be able to say that you tried it. And here's an image that we took from this excellent chapter by Jan Kasselman in the neuroimaging clinics, where he actually visualizes the fourth cranial nerve, although I'd be interested to hear your experience if anybody has solutions on how to see the fourth nerve more reliably, but it is probably the hardest one to see, even on a high-resolution KISS sequence with resolution down to 0.35, it's sometimes difficult to see the fourth nerve. Once it gets into the cavernous sinus, the mere mortals can visualize it again. It lives beneath the, at least just slightly medial to the fourth cranial nerve, or sorry, right beneath the third cranial nerve here and here on the left, and then continues out through the superior orbital fissure. So this patient presented with blurry vision, was diagnosed with a hypertropia, and has a lesion right along the course of the fourth cranial nerve that enhances. It's been stable now for 6 years, so we're calling it a fourth nerve schwannoma. The abducens nerve, or sixth cranial nerve, will typically present with an esotropia. Again, it can be different types of esotropia, many of which will not come to us for imaging, but acquired, especially acquired acute types will. And I did want to call your attention to this, a sensory type of esotropia, which also may, or sometimes we can assist in confirming a diagnosis. So if one looks at causes of esotropia, the studies have shown a prevalence of about 2% in children younger than 6 years of age, but then it drops off steadily as one heads toward adolescence. Many of the causes have to do with refractive errors, but paralytic and sensory will each account for about 7% of cases. Among the paralytic types of esotropia, it is important to consider a Duane retraction type syndrome that has genetic associations like the chimerin gene, but there are some as well cases of paralytic involvement of the sixth cranial nerve itself. And among the causes of sensory, esotropia. Some of these will be amenable to imaging, like optic nerve anomalies, optic nerve hypoplasia, and optic nerve coloboma. And again, depending on your confidence in the initial ophthalmologic evaluation and if the patient, which type of physician the patient's being referred to you, we may play a role in helping to make that diagnosis of a sensory esotropia. So the typical appearance of an esotropia, you can see in neutral position, this esodiviation of the affected right eye. In lateral gaze positions, the lateral rectus is not functioning, so the eye cannot esodiviate, and the diplopia worsens. So looking laterally up, laterally down, laterally horizontally, and in looking to the left, though, where the medial rectus can kick in, the eye can achieve a bifoveate vision. Because of the function of the medial rectus, so the diplopia tends to lessen. The sixth cranial nerve lives in the mid portion of the pons, just deep. The nucleus lives just deep to the facial colliculus, and then the nerve heads out, crossing through the corticospinal tracts, and then again heads into the cavernous sinus, and then through the superior orbital fissure. So again, you're going to use an axial T2 sequence to look at the lesion in the pons, and then a KISS sequence to follow the nerve through the cisternal segment up to the Dorello canal. Within the cavernous sinus, again, it can be seen just inferior and medial to the fourth nerve, heading out toward the superior orbital fissure. This 3-year-old boy presented with an esotropia and went to imaging, had a mass in the orbital apex. This lesion could have involved any of the cranial nerves. As you can see here, it's largely filling the entire superior orbital fissure, but chose to manifest principally as a sixth cranial nerve lesion. This is an example of a sensory esotropia. This 3-year-old boy presented with blurry vision. You can see here he has optic nerve hypoplasia on the right side, as shown on this coronal T2 weighted image. There's an axial T2 weighted image showing this very diminutive optic nerve on the right, and to see seen here, I think, as well on this coronal reformat from this KISS sequence along the cisternal segment. The septum is intact, and I'm showing you that hoping that I can convince you of a growing departure from overemphasis on the septum as a discriminator on referring patients with these types of lesions for endocrine workup, since many of the genes such as SOX2, OTX2, or PAX, some of the PAX mutations may in fact be associated with optic pathway malformations and endocrine dysfunction and leave intact the septum. So this oral notion of whether an eponymously designated like de Morsier or morphologically defined phenotype such as septo-optic dysplasia, I think is being somewhat re-evaluated in terms of the developments of neurogenetics. So for the fifth cranial nerve, just the anatomy of the fifth cranial nerve has protocol implications for us. It has 3 major divisions. It has a very long nucleus that ascends through the medulla up into the pons, all the way up into the mesencephalon, so it's a longer area to cover, and then extends out through the Gasserian ganglion and divides up into 3 branches labeled V1, V2, and V3, or the ophthalmic division, maxillary, and then the mandibular divisions. It has a motor component through the mandibular division. We use an axial T2 sequences to evaluate the nuclear component of the lesion, and then another KISS sequence to look at the fifth cranial nerve as it comes out through the pons, through the porus trigeminus into the Meckel caves, and then a coronal T1 high-resolution sequence to evaluate the nerve here, V1 and V2, and then entering foramen rotundum and more laterally into foramen ovale. This 7-year-old girl has right facial pain and has a lesion that is an anatomic study in part in fifth nerve morphology. You can see here it's going through the foramen ovale, expanding it, extending up into the Meckel cave. Looks as if it's involved in the anterior face of the foramen rotundum on the right compared to the left. And then you can see how it extends down through here it is going through foramen ovale on the CT, demineralizing foramen ovale and extending down along the course of the lingual and inferior alveolar nerves between the medial and lateral pterygoid muscles, and then into the mandibular canal that looks as if it's eroded, and then extending down inferiorly along the inferior alveolar nerve within the ramus of the mandible. So this pathology showed, in this case, a rhabdomyosarcoma. This is a 15-year-old where the nuclear portion of the nerve was more involved, and who presented with new onset facial numbness. He has findings consistent with multiple sclerosis, but he had a new lesion along the course of the trigeminal nucleus that lives just lateral to the facial colliculus. So for the facial nerve palsy in children, most cases are Bell's palsy, but there can be infectious and traumatic and congenital and neoplastic causes as well, for which the patients will come to us for imaging. So when do we image the nerve? When do you image a nerve? So actually, Doctors Cannell, Lindsay, and Hadlock at the Mass Eye and Ear tried to help us with that, and have suggested that the most important time point in evaluation of patients with facial paresis is at about at 4 months. So they suggest that depending on when the patient comes to them for evaluation, if the paralysis persists, continued complete flaccid paralysis at 4 months, they suggest imaging the nerve, even if the initial clinical findings were fit a Bell's palsy. Most of the time, a Bell's palsy, which is now considered to be, for the most part, a herpes simplex geniculate ganglionitis, most of the time, the clinical course, in the clinical course of the maximum severity of symptoms is reached by about 72 hours, and all branches of cranial nerve 7 are usually involved, since the lesion is thought to be involving a proximal portion of the nerve at the level of the geniculate ganglion. But if those symptoms don't resolve by about 4 months of age, those patients will come to us for imaging. The 7th cranial nerve lives in the mid portion of the pons. The nerve wraps around just posterior to the 6th nerve nucleus, and in part accounts for the bump along the facial colliculus, and then exits through the nervus intermedius, and then forms different branches, a temporal branch, a zygomatic branch, buccal branch, and marginal mandibular and cervical branches. There's also secretomotor fibers through the greater petrosal nerve and the chorda tympani, which we won't go into today. But in visualizing the major portions of the nerve, you're going to use a KISS sequence to look at the cisternal segment going into the internal auditory canal, and then pulse gadolinium axial T1 weighted images to look at the geniculate ganglion, the tympanic segment, and the mastoid segments of the nerve. Here they are in the coronal images as well. Here's the nerve traveling just inferior to the lateral semicircular canal and into the mastoid segment. So CT is very helpful as well in visualizing portions of the cranial nerve of the 7th nerve, the labyrinthine segment here, the little triangle of the geniculate segment, tympanic and mastoid segments seen in the axial and coronal planes. This girl presented with a left facial paresis that began about 1 year of age and then progressed over the next several years. So definitely not typical for a Bell's palsy. And her still photo shows some of the very typical findings. She has a depression of the oral commissure on the left, defacement of the nasolabial fold. She has incomplete closure of the lid, of the superior lid, because the orbicularis oculi muscle is innervated by 7 and closes the lid. And on smiling, she has denervation of her risorius and zygomaticus muscles, an incomplete smile, and this persistent depression of the oral commissure. So if you look at her, this will play. You can see here she's trying to close her eye. She has incomplete closure of the eye, except when she tries really hard. So that's pretty typical of a facial nerve palsy. Here she's going to, I think, try to smile. Still this adorable smile, doesn't she? And here she's puckering. And here she's trying to use her marginal mandibular bone. I'm not stressed right now, I promise. I'm just trying to show my inferior teeth with my marginal mandibular nerve. And here is actually her MR imaging that shows an enlarged, not only abnormally enhancing, but very large geniculate ganglion, tympanic segment, and mastoid segment. And here on the coronal images as well, here's the lesion coursing inferior to the lateral semicircular canal down the mastoid segment. This boy had a typical Bell's palsy, typical clinical course of a Bell's palsy, has some similar findings. The Bell's palsy is on the right. He has incomplete raising of his brow on the right side, incomplete closure on attempt to close the eye, widened palpebral fissure. You can see a decreased smile on the right side. And if we look at
and relax. Gently close your eyes and open. Squeeze the eyes closed and open. Gentle smile and relax. Big smile and relax. Go ooh and relax, and E and relax, and say 1, 2, 3,
1, 2, 3.
And happy birthday.
Happy birthday.
Okay, so just to show you part of the typical exam. So here he has findings that are characteristic of a Bell's palsy. He has this sort of patchy, hazy enhancement in the lateral portion of the internal auditory canal. So all portions of the facial nerve can enhance on post-GAD T1 except for the canalicular portion. So this hazy enhancement here would be atypical, and sometimes one will see as well some asymmetric enhancement. Here I think I can convince you, if I can, the geniculate ganglion is a little bit more enhancing on the right side than on the left. This was an 18-year-old who had left facial paresis, but in addition to that, she had some atypical findings for Bell's with hearing loss and vesicular eruption in her right ear that was thought to be more consistent with a herpes zoster oticus. Here she, again, in her still photos, she has incomplete raising of her brow on the left. She has incomplete closure of the lid, and you can see a decreased smile on the left side as well. And although on her post-gadolinium images, she has really just asymmetric enhancement along the tympanic segment of the 7th cranial nerve, in this clinical setting, the findings would be consistent with inflammation. This girl, just to show you other infectious causes of facial nerve palsies, has had an acute onset of a right facial paralysis after an episode of acute otitis media. Here she's unable to raise her right brow on the side. You can kind of get the recurring theme here. She has a decreased smile on the right side, incomplete closure of the lid, and the CT really showed these nondescript opacification of the middle ear cavity. Here you can see in both axial and coronal images as opposed to the left side. And although it's important for us sometimes, if we're sure that there is a dehiscence along the course of the 7th cranial nerve, to warn the otoscopist of that beforehand, you can see here that compared to the normal left side, that there are segments along the tympanic nerve where if one were to place opacity there, it may simulate an area of dehiscence. So I tend to be more cautious in my interpretation of the images and try to avoid the false positives. And it's important to keep in mind that even in the normal facial nerve canal, there may be segmental areas where the osseous margin is less well defined. This is a 4-year-old girl with a left congenital facial paresis. If I can't convince you that her facial nerve is small on the axial images on the left side, diminutive here, compared to the right, I'm hoping I can do that on the sagittal obliques, because that's really the point of this case, is to show you the utility of doing sagittal oblique images. Here's the normal appearing facial nerve, so the 7 up, so the 7th nerve in the anterior and superior portion of the internal auditory canal, and here is the hypoplastic nerve on the left. So sometimes, if you're not sure on the axial images, doing these sagittal obliques is helpful. And this boy man presented later at 22 years of age for a second opinion, but when he came with his parents, who said that he's had this left facial paresis all his life, and that the MRIs have always shown abnormal enhancement. So that should be a red flag, because if it is a Bell's palsy, the enhancement should eventually go away. This patient then had thought that he was getting slightly better, but he was sent for imaging. This is his photo as a child. Here, and this is his photo years later, but he still has a very decreased smile on the left side, and he had a very thick enhancing nerve that we thought was more consistent, again, with a schwannoma. So nothing really along the cisternal segment of the nerve, but this abnormal thickened nerve on the left side. That we thought would not really be consistent with just an inflammation. So deafness is estimated by some, for instance, Hilgert and Morton and Nance, to be the most common birth defect in children, affecting as many as 1 in 500 children. Or about 50% of causes are genetic, both syndromic, 70%, and are non-syndromic, 70%, and syndromic, about 30%. There are hundreds of genes now associated with hearing loss. It is dizzying. Sorry about that pun, but it's every time one looks in OMIM, there are more and more genes that are associated with hearing loss. But again, to put you in the driver's seat of the otologist evaluating the patient comes to you for hearing loss, you're going to do an audiogram and try to characterize the hearing as conductive or sensory neural. If it's sensory neural and unilateral, those patients will definitely come to us for imaging. And in terms of the anatomy of the nerve, you know that the sound waves are transmitted through the middle ear cavity. Fluid wave through the scala vestibuli is turned into electric pulsation and transmitted back through the cochlear fibers to the dorsal and ventral cochlear nerves. We use a KISS image to look at the cochlear nerve and the vestibular branches, and we use, again, a sagittal oblique to see the four portions of the nerve here, the seventh nerve, cochlear nerve inferiorly, and the two vestibular branches posteriorly. This is a 12-year-old girl who had an audiogram showing a sensory neural hearing loss, and on imaging, unilateral sensory neural hearing loss showed an enhancing mass in the left internal auditory canal. So she did not meet phenotypic criteria for NF2, and the genetic testing is pending. But this is a boy who presented with a unilateral sensory neural hearing loss, and again, I'm going to try to show you the use of the sagittal oblique images. The right nerve here is normal. The left nerve looks small on the axial, but one's always concerned about volume averaging. But if one does a sagittal oblique, you can see that the abnormal hypoplastic nerve on the left side compared to the more normal right cochlear nerve. In this 4-month-old girl who had bilateral sensory neural hearing loss and no evidence of cochlear nerve on either side, patients like this are consideration now for auditory brainstem implantation. Some of the first cases are being done in Boston, and those have started probably within the last year or so. So some of those patients are now who were previously not candidates for cochlear implantation are candidates for ABIs. For cranial nerves 9, 10, and 11. Probably the most frequent referral to us is going to be for evaluation of patients with vocal fold paresis. In this study of 400 and some patients, most patients present under 12 months with vocal fold paresis. Most of those cases are unilateral, and by far and away, most of them are secondary to cardiac surgery, although there are some neurologic cases that will come to us for imaging. In terms of just looking at the jugular foramen, the 10th, 11th, and 9th nerves are very closely approximated within the jugular foramen. And so the jugular foramen is a very important point of evaluation for pathology in these cases. So for imaging technique, you're going to use a KISS sequence to look at the cisternal portions of the nerve. I like to do an oblique sagittal to try to distinguish 9th and 10th nerves from one another, and then axial T1 images through the jugular foramen to look at the nerves along this segment. This 14-year-old boy who presented with cough and dysphagia is pretty much a case study in skull base anatomy. He had this large lesion that surrounded the internal and external carotid and rose all the way up to involve the jugular foramen and hypoglossal canals here. You can see on the PulseGAD on the CT bone windows, the hypoglossal nerve here on the normal side and the normal jugular foramen, pars vasculosa and nervosa, whereas on the right side there's demineralization and loss of the normal cortical edge along all of these skull base foramina where the lesion has risen up into the skull base. So this 4-year-old girl presented with hoarseness for 1 month. She had an ENT evaluation, right vocal fold paresis, and you can see she has this really hyperostotic appearance of the petrous temporal bone that starts all the way anteriorly, involves the petrosal fossula going into the pars nervosa. There's hyperostosis along the whole cisternal segment of the petrous bone all the way back into the jugular foramen. On the MR, you can see there's an extra osseous component that's protruding medially into the cistern, and then medially as well on the contralateral side of the hyperostotic component of the mass into the middle ear cavity. So features that, although unusual for her age, are suggestive of a meningioma, and the pathology in fact confirmed that. So several different institutions have weighed in on that pathology. But in cranial nerve 12, the hypoglossal nerve extends from the medulla inferiorly into to innervate the tongue, and at the level and lower down at the level of the tongue passes between the mylohyoid and the styloglossus hyoglossus complex. So you're going to use a KISS sequence to evaluate evaluate the hypoglossal nerve along the cistern, and again, a pulse-guided axial T1 to look at the nerve as it passes through the jugular foramen. And this is a patient who presented with had a history of neurofibromatosis, but had bilateral tongue weakness and had bilateral, worse on the left than on the right, and had bilateral lesions along the course of the 12th nerve going into the hypoglossal canal. So just to wrap it up, take-home messages. Cranial nerve 1 imaging may have a higher hit rate in children than in adults, so don't let your adult colleagues dissuade you sometimes for imaging children with olfactory disturbances. So don't remember those fundi, and having those in mind, I think, can sometimes help us as we evaluate patients with vision loss. For the nerves involved in strabismus, exotropia, hypertropia, and esotropia are all evaluated in that clinical setting. We almost always will image patients with suspected cranial nerve 3 palsies because of the high incidence of congenital lesions. We almost never image patients with cranial nerve 4 palsies. And remember that for cranial nerve 6, it may be helpful sometimes to image along the optic pathway to pick up those cases of sensory esotropia. So remember your high-resolution coronal T1s and evaluation of the 5th nerve. Follow up the enhancing lesions along the 7th nerve to make sure that the enhancement resolves if it is in fact a Bell's palsy. And for cranial nerve 8, keep in mind those sagittal obliques and the importance of using those. And for cranial nerves 9, 10, 11, and 12, remember some of these nerves, for instance 10, have a very long course, which affects our protocol, and that the jugular foramen is an important structure for looking for pathology for those nerves.